Today we will be discussing about pancreas. We would be discussing in detail about the anatomy, the embryology, the arterial supply, venous drainage, lymphatic drainage, variations, and the radiological features. The pancreas is located in the abdomen, in the upper quadrant, where it is surrounded by the gallbladder and the second and third part of the duodenum on the left, and maybe a lateral aspect, you have the spleen, and the superior medial aspect, you have the liver. The pancreatic contains the pancreatic ducts, which drain into the pancreatic acini. It is broadly divided into three parts: head, body, and tail, where the head has an uncinate process. The anatomy: the pancreas is situated on the posterior abdominal wall at the approximately L1 level. It is divided into head, neck, body, and tail. It is a retroperitoneal organ, with the exception of the tail, which lies in the splenorenal ligament. It is around 15 centimeters long, and it lies transversely and slightly oblique, with its tail higher than the head. The head of the pancreas lies in the curvature of the duodenum, with the pylorus of the duodenal bulb overlapping it slightly on its upper surface. The uncinate process projects posteriorly and to left from its lower part to lie posterior to the supramesenteric vessels. The remaining part of the pancreatic head lies anterior to the vessels of the posterior abdominal wall, that is the vena cava and the renal veins, the aorta and its celiac and superior mesenteric branches. The common bile duct passes posterior to the head of the pancreas in a groove or tunnel towards its termination in the second part of the duodenum. The neck of the pancreas extends from the upper part of the anterior portion of the head. It lies anterior to the union of the splenic vein and superior mesenteric vein to form the portal vein. The body of pancreas curves over the vertebrae and the great vessels to reach the left paravertebral gutter. The splenic vein passes posterior to the body, where it receives the inferior mesenteric vein. The splenic artery runs along the upper surface of the pancreas in a sinuous course that is intermittently above and behind the pancreas. The body lies anterior to the left kidney and the adrenal gland. The tail is related to the splenic hilum, and it lies in the splenorenal ligament. The architecture is finely lobulated with multiple microlobulations. Now, when we come to the relationships of pancreas, the relationship, as I told you, would be medially associated with the duodenum and the transverse colon. A part of the transverse colon would be posterior to the pancreas. The peritoneum and the small intestine would be anterior to it. Peritoneum and lysosac of the stomach would be supromedial aspect of the pancreas. The line of attachment of the transverse mesocolon would be posterior to the body of the pancreas. The superior mesenteric vessels are seen to course behind posteriorly to the body of the pancreas and cross over the uncinate process. The anterior relations include the posterior relations include aorta, splenic vein, and the uncinate process in the anteriorly. And posteriorly, you have the suprarenal gland in the diaphragm. Embryology. Pancreas develops from two endodermal buds, the dorsal and the ventral buds, that arise from the part of the gut that later forms the second part of the duodenum. The ventral bud arises in close relation to the hepatic bud in the inferior angle. The dorsal bud arises from the dorsal aspect of the gut and grows into the mesoduodenum and into the dorsal mesogastrium. When the duodenal loops fall to the right, the ventral bud comes to a point to the right and the dorsal bud to the left. As a result of differentiation in the growth of the wall of the gut, the attachment of the ventral bud along with the bile duct shifts to the left side. Pancreatic tissues formed from these two buds fuses to form one mass. The ventral bud forms the lower part of the head and uncinate process, and the dorsal bud forms the upper part of the head and body and the tail. The ducts of the pancreas then anastomose with each other, and the dorsal duct of the pancreas between its anastomosis and the duodenum remains narrow and forms an accessory pancreatic duct. The main pancreatic duct thus is formed by the distal part of the duct of the dorsal bud and its proximal part of the duct by a ventral bud. The main pancreatic duct opens into the duodenum and a major duodenal papilla along with the bile duct. The secretory elements of pancreas are formed by a proliferative and primitive ducts. Proliferation of the primitive ducts. The islet cell of Langerhans are also derived from the primitive ducts system. So this is an image which shows where the hepatic diverticulum and the ventral and dorsal pancreatic buds, which form in the early part of the gut formation. When there is a rotation of the gut with a differentiation, the dorsal and ventral pancreatic duct are formed enlarged in their size, and then later they go on to get fused with the accessory pancreatic duct becoming narrow, and the dorsal when main pancreatic duct becoming broad, which forms the head, body, and tail of the pancreas. The initial formation of the stomach and all the dorsal pancreas will begin at 5 weeks of gestation, and they would be complete fuse at 8 weeks of gestation. The arterial supply of the pancreas. Pancreas is supplied by branches of celiac and supramesenteric arteries. Celiac artery branches via its hepatic and splenic arteries. The gastroduodenal artery arising from the hepatic artery divides into right gastroepiploid and superior pancreaticoduodenal artery. The superior pancreaticoduodenal artery divides early onto an anterior branch that lies in the groove between the pancreas and the duodenum, and a posterior branch that passes posterior to the pancreatic head. The splenic artery passes along the upper surface of the pancreas and supplies mainly the small branches to it. One of these is sometimes larger than the others, and it's called a pancreatic Magna artery. The dorsal pancreatic artery arises close to the origin of the splenic artery and passes vertically downwards behind the pancreas. It divides at right angles into a left branch which passes towards the tail of the pancreas as a transverse pancreatic artery, and a right branch which passes to the neck and uncinate process which anastomose with the arteries on the anterior surface of the gland. The inferior pancreaticoduodenal artery arises from the right side of the superior mesenteric artery. It divides early into anterior and posterior branches that anastomose with those of the superior pancreaticoduodenal artery. Now, this is a broad classification of how the pancreas is being on the vessel bifurcations and supply. The pancreatic behind the pancreas, there is a celiac artery and the superior mesenteric artery, where celiac artery, there is splenic arteries and the hepatic artery, from which the gastroduodenal artery and many small branches supply the pancreas. The superior mesenteric artery has the inferior pancreaticoduodenal artery, which has an anterior branch, and the posterior branch, which anastomose to form the superior pancreaticoduodenal artery. Coming to venous drainage, the neck, body, and tail drain into the splenic veins, and the head drains into the superior mesenteric veins and the portal veins. The lymphatic drainage would include the nodes along the course of the supplying the arteries to the pre-aortic celiac nodes. Coming to the normal anatomical variations, pancreatic divism is one of the most common anatomical variation to be encountered in the common practice. The failure of fusion of dorsal and ventral moieties result in the anterosuperior part of the head, body, and tail draining separately via the accessory papilla, while the posterior inferior part of the head drains to the ampulla. This is the commonest variations. In annular pancreas, the rare condition where the ventral pancreatic butt rotates incompletely, leaving a segment of the pancreatic tissue surrounding the second part of duodenum, which might be one of the most common causes of secondary to D2 segment obstruction of the duodenum. Agenesis of dorsal pancreatic moiety, where the pancreatic head is present but no body or tail is seen, but it is a very rare presentation. Pancreatic rests or ectopic pancreatic cells can be seen along the migratory cells, which can be seen along the gastric stomach or accessory nodules of the pancreatic tissue, which occur on the wall of the stomach, the duodenum, the small intestine, or with the Nichols diverticulum. So the most common site of the wall of the duodenum closest to the pancreas and close to the opening of the pancreatic duct are common locations for the pancreatic cells or the ectopic pancreatic cells. The variation in normal anatomy of the pancreatic ducts. Atrophy of the accessory duct persists with a tiny duct in 60%. The radiological features. It is defined ultrasound. When you see the transverse sections anterior to the splenic vein, it has a characteristic sonological feature where the celiac artery division into splenic and hepatic veins in the right angles can be very easily identified. The hepatic artery and bile ducts are seen anterior to the portal vein and also scapulaire to the pancreatic head. The antrum of the stomach may be identified anteriorly with the pylorus and duodenum above and curving around the right side of the head. In the upper part of the head, two round anechoic structures can be identified. A cross-sectional view of the gastroduodenal artery anteriorly and common bile duct posteriorly. These demarcate the right side of the head of the pancreas from the duodenum. Head and neck of pancreas are seen in midline anterior to the confluence of the splenic and superior mesenteric veins. Just posterior to this, the left radial vein is usually seen crossing the aorta to drain into the IVC. The uncinate process is identified posterior to the superior mesenteric vessels. The neck of the gland is identified in transverse and sagittal images anterior to the confluence of superior mesenteric and splenic veins. The body runs anterior to the splenic vein along the midline. The tail is viewed by angling the transducer superolaterally from the midline to the splenic hilum or by oblique views through the spleen. The pancreatic duct is seen within the gland closer to its anterior surface. It is best seen on the central portion of the body where it is perpendicular to the plane of the image. It measures approximately 1.5 mm in the tail, 2 mm in body, and 3 mm in head. The ecotexture of the pancreas is normally homogeneous and it's slightly hyperechoic with respect to the liver. It may be hyperechoic in aging and obesity due to the presence of fat or fatty degeneration. In CT, the tail is visible at the splenic hilum on the highest slices and the uncinate process in the lowest part. Normal thickness of the head is around 2 centimeters with neck of around 0.5 to 1 centimeter. The body and tail will be around approximately 1 to 2 centimeters. The height of the head is very well and measures up to 8 centimeters. The height of the body and tail may measure up to 3 to 4 centimeters. The pancreas has the shortest T1 of the abdominal organs and therefore higher signal intensity on T1 will be equivalent or slightly higher than that of the normal liver. Intrinsic contrast is very good on T1 imaging, especially when the surrounding fat has been suppressed. So the pancreas is seen well also on T2 and faster sequences, which include breath holding techniques to reduce artifact from breathing. The pancreas is very vascular and enhances intensely during the arterial phase of the gadolinium bolus. In ERCP or endoscopic pancreatography, it visualizes the pancreatic duct by injection of the contrast after cannulation via diurnal endoscopy. The main duct is cannulated in a common with the bile duct when the anatomy of the bile duct is normal. The main duct is seen to begin by the union of small ducts in the tail. It passes obliquely downwards and to the right across the L1 vertebrae and ends in the dilated ampulla before entering into the duodenum. The duct is around approximately 16 centimeters long and measures up to 4 mm in diameter of maximum thickness. The accessory duct may be filled via its communication and seen to pass anteriorly and superiorly to the main pancreatic duct. The branches which join the main pancreatic duct are at right angles. A pancreaticogram, which is obtained when enough contrast is injected into the filled acini and the ducts. The pancreatic duct measurements are higher on ERCP than MRCP and USG because they distend the duct completely and they are filled with contrast in ERCP. Thus, for endoluminal pathologies, these serve as better demonstrative measures when compared to ERCP, so when compared to MRCP and non-invasive techniques.